His elbow was shot full of cortisone several times a season. His stomach was always queasy from the cocktail of anti-inflammatories he swallowed before and after games, which he once said made him half high on the mound. He soaked his elbow in an ice bath for 30 minutes after each game, his arm encased in an inner tube to protect against frostbite, and even then his arm would swell an inch. He could not go on like this, not when his doctors could not rule out the possibility that he was risking permanent damage to his arm. The 2020 NBA Western Conference Finals. It was nearing midnight, and Jamal Murray concluded his post-game news conference by slowly rising from his folding chair with the expression of someone who had spent 12 hours on an assembly line. He had football-size ice packs on his knees. As he lumbered toward the door and a waiting bus outside, he let out a loud groan. And here you have another great, LeBron James, with double ice packs on knees, as well as ankles post-game. So is ice the right thing to do? As we know, ankles are the most common sports injury, ankle sprains. And the first thing a doctor usually tells a patient to do is throw an ice pack on it. You hear that from coaches on the sidelines. You hear that from parents on the sidelines. You hear that from doctors in doctors' offices. But is ice really the right way to go, especially considering we've been hearing this for decade after decade after decade? The most common acronym in sports medicine is RICE: rest, ice, compression, elevation. Let's dig into this topic a little bit and find out a little bit more if this is the right thing to do or not. The history of cryotherapy. The Edwin Smith Papyrus, the most ancient medical text known, dated 3500 BC, made numerous references to the use of cold as therapy. The Hippocratic School of Medicine used total body cooling for tetanus treatment during the 4th and 5th centuries BC. Dominique Leray, Napoleon's legendary surgeon, used it to facilitate amputations during his historic retreat from Moscow in 1812. Between 1845 and 1851, Dr. Brighton of England described the benefits of local cold application in the treatment of numerous conditions, including headaches and neuralgia. He recognized the analgesic numbing effect of cold, recommending its use to anesthetize the skin before surgery. On May 23, 1962, 12-year-old Eddie Knowles jumped onto a freight train in Somerville, Massachusetts, resulting in his arm being completely severed from his body. The young boy was taken to Mass General Hospital, where Dr. Ron Malt, a young chief resident, attempted to save Eddie's detached limb. Despite the fact there had never been a successful reattachment of a major limb recorded in the medical literature, Dr. Malt and a team of 12 doctors performed the first successful limb reattachment in history. The operation's success quickly became a global phenomenon. Newscasters swarmed the team of doctors to obtain essential facts about the miracle limb reattachment touted as one of the most monumental operations in medical history. However, the essential facts about the surgery were rather complicated and would not be understood by the general public. Instead, reporters focused on the aspects of the story that would be intriguing to the reader. As a result, the application of ice to preserve the severed tissue became the main focus of the story. Subsequently, as the story was continuously retold by individuals not directly involved in the surgery, facts began to change. You know how that works. Eventually, the general public was quickly accepting the notion that any injury could be treated with the application of ice regardless of its severity or how it occurred. Gabe Mirkin and Rice. Gabe says, "When I wrote my best-selling sports medicine book in 1978, I coined the term RICE, rest, ice, compression, elevation for the treatment of athletic injuries. Ice has been a standard treatment for injuries and sore muscles because it helps to relieve pain caused by injured tissue. Coaches have used my RICE guideline for decades, but now, let's look a little bit deeper. So what is the rationale for RICE? The benefits of RICE can be explained by stage. Rest. Immobilization supposedly prevents further injury and gives the body time to recover. But what does immobilization mean, and for how long should you immobilize? Ice. Cold reduces pain by numbing the affected area. 1, is that a good thing? How do we do it? What are the methods of cold? Compression. Pressure keeps swelling under control. Well, is that a good thing? Elevation. Keeping the injured body part above the heart reduces swelling and the associated pain and discomfort. Same questions. So, yes or no? Here we have a website, Verywell Health, and we have 2 articles dated the year 2020. RICE, treatment for acute musculoskeletal injury, self-care to reduce pain and swelling with soft tissue injuries. And the next article, why you shouldn't do RICE for sprains. Is there another method that's better? So same website, same year, 2 different protocols. Yes or no? So where did this all come from? Well, after doing quite a bit of research on PubMed, found some very interesting papers that date back 60 years. The use of cold packs for increasing joint range of motion, a study in 1958. And this historical background will help you understand where all this came from. When 5 physical therapy students arrived at Letterman Army Hospital for their clinical affiliation, they were surprised to note the frequency with which cold, wet towels were administered to sore, stiff joints. Most of these treatments included exercise of varying degrees. Joint range of motion, limited by pain, was increased by local cold applications, but there was no statistical data to alleviate the subjectivity of this observation, nor to prove whether cold packs alone or cold packs and exercise were more beneficial. Therefore, throughout the months of June, July, and August in 1957, the students carried out a study to investigate further the application of cold as a therapeutic agent. The literature was reviewed to learn what effects cold has on the body. Much is still controversial and unknown about the exact reaction of the body to short applications of cold, but the belief that pain will be decreased and joint range of motion increase with cold applications or with cold and exercise seems justified from the available information. Remember, this is 1958. The patients were divided into 2 groups for a comparison between the effects of cold packs alone and cold packs plus exercise. Patients who started treatment on the odd days of the month were placed in Group A and received cold packs as the only treatment. Patients starting on even days were placed in Group B and were treated with cold packs and ice. The routine for the treatment was as follows. Range of motion of the affected joint was measured each day before treatment and recorded on a special form. Towels immersed in a bucket of ice cubes and water were gently wrung and applied to the affected area for 1-minute intervals with 8 changes of towels. The temperature of the water remained a constant 34 degrees Fahrenheit. 2 towels were used for each area treated so that one was soaked in the ice water until the moment it replaced the pack on the patient. The range of motion was taken and recorded after each treatment. Group B was started on exercise after the 4th application was completed. Exercise continued throughout the remainder of the cold applications and often beyond. Exercise was active only, with the exception of proprioceptive neuromuscular technique for the low back pain group. The range of motion was measured after the treatment. The conclusions made from this study are as follows. Joint range of motion, which has been limited by pain, can be increased with local application of cold. 2. There is a greater increase in range of motion during each treatment when the patient receives cold packs and exercise. 3. With overall increase of motion and decrease as the criteria in the study, cold packs alone seem to be the more effective beneficial treatment for lower back pain with limitation of motion. This was also true of right and left rotation of the neck. Cold packs plus exercise produce more favorable results in flexion and extension of the neck. Due to the extremely small series studied, these apparent variations may not be valid and further study is necessary. 4. Relief of pain was approximately equal in both groups. Medication did not seem to make a significant difference in the results. That was really interesting to me. Going back 60 years, medication didn't seem to make a difference. What do we do today? Anti-inflammatory after anti-inflammatory after anti-inflammatory. Yet they knew better 60 years ago. It is felt that this work is only a beginning and that more study of many more patients must be done before it can be determined just how beneficial cold treatments are, whether exercise is a valuable adjunct to them, and whether one joint or diagnosis responds better to cold treatment than another. It is hoped that therapists in other medical installations will extend this study and provide additional information on cold therapy in physical therapy. Let's look at another study, this dated 1962, cryokinetics in an early treatment program. Again in the military, the Army soldier who seeks medical attention for acute or painful musculoskeletal conditions usually stops first at his designated dispensary where the attending surgeon determines the course of treatment. If the condition warrants more than simple medication, the soldier proceeds to the appropriate clinic or clinics. He may be referred directly to the physical therapy clinic, but too often his arrival is delayed. As a result, the condition may have deteriorated and recovery may be prolonged. For a soldier in training, the loss of duty time may have serious consequences. It may even result in his need to repeat the entire training cycle. Most soldiers, therefore, are not disposed to malinger. To provide better medical services for the soldier in training, a 3-phase program was designed. This paper was originally presented at the 39th Annual Conference of the American Physical Therapy Association in 1962. The program included immediate physical therapy following physician consultation, treatment by one simple method, an early shift of responsibility for treatment from the physical therapist to the patient. Soldiers continued to report first to the attending surgeon at the dispensary. If they were suffering from acute or painful musculoskeletal conditions and physical therapy was indicated, they were referred immediately to the physical therapist at the dispensary. Cryokinetics, the term selected to describe the therapeutic procedures used in the program, denoted the two essential components of the treatment, cold and motion. Equal in importance to early therapy and to the method of treatment was the transfer of responsibility for treatment to the patient. Treatment goals included early recovery, prompt return to duty, and therefore reduction in loss of training time. This paper describes the program and reports the results in terms of goal achievement for the first 1,000 patients in the program. Of these 1,000 patients treated, as described above, 850 returned to duty within 1 hour after reporting for treatment. 970 returned to duty the same day they reported. All except 3 patients returned to duty within 2 days. 3 patients were referred to the orthopedic clinic. A total of 934 patients reported to the attending surgeon 1 time. 64 reported 2 times, and 5 reported 3 times. The number of treatments patients received in physical therapy was 906 received 1 treatment, 73 received 2 treatments. 17 received 3 treatments. 3 received 4 treatments, and 1 patient received 5 treatments. Although figures are not available to show the statistical superiority of this method of management of acute musculoskeletal conditions, medical and physical therapy officers at the Brooke Army Medical Center believe that the goals of the program were achieved. That is, a reduction in the loss of training time was accomplished because earlier recovery permitted earlier return to duty. The high percentage of patients returned to duty the same day would tend to bear out the effectiveness of the program. The participation of the patient is considered of high importance in this type of program. Both the attending surgeon and the physical therapist stress to the patient his responsibility for recovery, and they explain to him the anticipated positive effects of the treatment. This approach is in keeping with the principles practiced increasingly in medicine today, in which the development of dependency is avoided by the patient's recognition of his own responsibility for self-care and recovery. Wow! This is 1962. I have to read that again. This approach is in keeping with the principles practiced increasingly in medicine today, in which the development of dependency is avoided by the patient's recognition of his own responsibility for self-care and recovery. So now you can see that ICE is gaining a foothold in the treatment of musculoskeletal injuries from these studies done on recruits at military installations. Here we have another paper, 1964, Massage with ICE, again called Cryokinetics, in the treatment of painful conditions of the musculoskeletal system. Institution of normal function is now being accepted by most physicians as a major goal in the treatment of common painful conditions of the musculoskeletal system. The major impediment to achieving this goal is the pain and discomfort usually attendant to such motion. That's a critical comment as to why ICE is being used so frequently and, frankly, successfully to this point. But we need to examine what does success mean and why did success occur. The multiplicity of physical and pharmacological agents available for relief of pain in these conditions bespeaks of the lack of a predictably rapid and uniformly satisfactory response to any one agent or combination of agents. This paper outlines a simple and highly effective program of treatment consisting of local application of cold by a specific technique followed by mobilization exercises. Are you seeing a pattern here? Cold followed by exercise for use in this group of conditions. Over a 21-year period, this treatment program has been applied to over 7,000 patients with various acute and chronic painful conditions of the musculoskeletal system. Now we jump to 1970, a paper, Physical Medicine in Athletic Rehabilitation. ICE has become an acronym. The paper says probably the most common indication for the use of cold therapy is relief immediately after trauma. It will decrease pain and produce a local vasoconstriction, which will result in decreased hemorrhage and edema. A researcher and doctor named Brown has mentioned the mnemonic ICE as a guide to acute injury management. ICE, compression, elevation. So you see here the acronym ICE goes as far back, at least as I've found, to 1970, which predates Gabe Merkin's RICE mnemonic by 8 years. Let's jump to 1977, a literary review on ICE therapy in injuries. This paper says the application of compresses using either cold or heat has been a time-honored treatment for traumatic, inflammatory, and painful afflictions. In large measure, these treatments have been applied in an empiric manner, with little scientific justification for their use other than that they seem to assist recovery. The use of local cold therapy can produce temporary dampening of spasticity, probably by decreasing the responsiveness of the muscle spindles to stretch. Cold applications can also enhance voluntary control in spastic conditions, and in acute traumatic conditions may decrease painful spasms which result from local muscle irritability. As a secondary beneficial therapeutic effect, cold does depress the excitability of free nerve endings and peripheral nerve fibers, increasing pain threshold. This effect is of great value in acute treatment. However, its injudicious use can contribute to serious injury. The loss of protective pain sensibility after local icing is probably a contraindication to athletic participation. Wow, 1977. Wow. Additional effects of cold application include decrease in blood flow, decrease in inflammatory response, decrease in local edema production, a decrease in hemorrhage, probably as a result of local reduction of blood flow. For these same reasons, ice packs have also been used after orthopedic surgical procedures to reduce local tissue reaction and to hasten recovery. Cold therapy can be useful in treatment of the acute phase of inflammatory conditions such as bursitis, tenosynovitis, tendinitis, where the application of heat may result in additional congestion of tissues and increased pain. If its temperature is lower than 0 degrees centigrade and it is applied directly to the tissues, particularly with compression, freezing of the superficial tissues can occur. In applications of over 30 minutes, blood flow does alternately increase and decrease in the tissues being cooled. This so-called hunting reaction or hunting response is a protective phenomenon which attempts to maintain temperatures of the tissue at a viable level and will protect them from thermal injury. And the very famous Dr. James Nichols, the orthopedic surgeon of the time, made an interesting commentary to this paper. He said, "This paper raises many interesting questions." Now, bear the date, 1977. What does ice do in intermittent sports performance as opposed to continual performance in hot weather and in wet or dry weather? What is the effect when used with massage and heat, and at what level? In other words, ice for acute injuries has many fascinating spin-off implications for research, just as heat for the later convalescing injury has. Such research will help us learn what is meant by relaxation versus stiffness, and the loose versus tight feeling alluded to by so many athletes in their warm-ups. So here we have questions about ice and whether or not ice, why it works, is it the best thing to do? And this goes back a long time. So now you're seeing some of the history of why ice became such an accepted treatment method. But there were really always questions about whether it was the ice, whether it was about that exercise based on the studies at the military institutions in the late 50s and early 60s. So what really was going on? Let's jump now to 1986, the use of cryotherapy in sports injuries. So as far back as 86, the research, there was some skepticism. Most clinical studies report that the use of cryotherapy has a positive effect on pain reduction and on the recovery of various injuries. When the physiological processes produced by cryotherapy are examined in experimental situations, some of these reactions differ from expectations. The therapeutic application is usually with ice packs, ice towels, or ice massage to the injured part of the body. Another application technique mostly used in research, at least at the time in 1986, because of the ability to control the temperature, is an immersion in cold water. Local cryotherapy is also provided by frozen gel packs and ethyl chloride or other vapocoolants. Decreased skin, subcutaneous muscle, and joint temperature. That's one effect of icing. Vasoconstriction, decreasing the blood flow. Local cooling may also affect almost every component of the neuromuscular complex, including the motor neuron pool, the muscle spindle and its afferents, the skin afferents, the myoneural junction, and the extrafusal fibers of the muscle. So neuromuscularly, there are some pretty significant effects going on by local cooling. The cold reduces nerve conduction velocity, the activity of the muscle spindle, the stretch reflex response, and spasticity. So think about this with regard to return to play. Clinical as well as experimental research on pain and the pain threshold indicates that pain reduction occurs after cooling to temperatures around 10 to 15 degrees centigrade, although some uncertainty exists as to the duration of the analgesic effect. The mechanism of pain relief is believed to be due to the breaking of the pain cycle, wherein pain provokes muscle spasm, and this in turn produces an increase in the pain. As shown by transillumination technique in our experiments, says the study, the lymph vessels begin to disintegrate because of the extreme cold application. So here's the first mention of lymph vessels. Considering that the lymph system is one of the major mechanisms in fluid evacuation, this temporary change in the structure of the lymph vessels in combination with the augmented extravascular protein concentration and subsequent accumulation of extravascular fluid could be one of the reasons for the increase of the swelling after cold therapy, even in uninjured ankles. The use of intense cold or prolonged use, even of less extreme temperatures, may have deleterious effect on the volume recovery. In sports injuries, the finding that cold is more effective than heat in reducing the level of electrical activity in the muscle is attributed to the muscle spindle response. In general, cold causes a decrease in the electrical activity of the muscle spindle by increasing the threshold stimulus for firing and thus decreasing the afferent firing rate. Let's slow down a second and relook at some of the clinical aspects of muscular injury. This is a chart taken from a little over 30 years ago. Table 1, categories of presentation of muscle injury. So we have the acute injury, the chronic injury, an acute exacerbation of the chronic injury, or a subclinical injury. So first we have to have some type of tissue overload, some forces that exceed the ability of the tissue to absorb those forces, which leads to tissue injury, which can lead to clinical symptoms. These clinical symptoms can be inflexibility, causes weakness, imbalance, so there's some type of functional biomechanical deficit that the tissue injury causes, and these lead to some type of functional adaptations. And it becomes a vicious cycle if therapy is not complete. Hence, what is one of the most common reasons for injury? Well, it's prior injury because the athlete is not fully recovered. So here are the stages of analgesia induced by cold therapy, again from 1986, and this paper says no specific data are available to verify the effectiveness of ice. So again, in 1986, where's the data for ice use? But in situations where edema is a prominent feature, logic, and they always say logic would suggest that these practices assist in overcoming gravitational impediments to the reduction of swelling. But if there's no data, why is this logical? We'll look into that a little more deeply. So what are the stages of analgesia induced by cold therapy? Well, stage 1, cold sensation, somewhere between 0 and 3 minutes. This is all depending upon the person. Stage 2, burning, aching, 2 minutes to 7 minutes. Number 3, local numbness, anesthesia, 5 to 12 minutes. And the deep tissue vasodilation, 12 to 15 minutes, cold, burning, aching, numbness. Now, do textbooks agree on their advice with regard to ice? Well, in 2001, This paper says, in 17 textbooks, there was no guidance on the duration, frequency, or length of ice treatment, or on the use of barriers between the ice and the skin. Advice on treatment duration was given in 28 texts, but recommendations differed depending on the particular ice therapy, injury location, or severity. There was considerable variation in the recommended duration and frequency of advised treatments. So let's look at this paper, Cold Therapy of Athletic Injuries, Current Literature Review in 2001. The application of a cold pack reduces local muscular blood flow by approximately 50% after 10 minutes. The duration of bleeding in a muscular injury is not known, but immediate application of external pressure is probably far superior in emergency treatment of an injury. Some studies have shown significant effect of cryotherapy in emergency treatment of ankle sprains, but external pressure is often applied simultaneously, and the additive effect of cryotherapy is therefore uncertain. Cryotherapy reduces the metabolic rate in injured muscle and is often used several days after a soft tissue injury to reduce secondary hypoxic injury. Experimental studies, however, show no effect of cryotherapy on muscle regeneration, and no controlled clinical study has shown a significant effect in emergency treatment of soft tissue sports injuries. So here we go back 20 years. No controlled clinical study has shown a significant effect in emergency treatment of soft tissue sports injuries. So why have we been doing it? I graduated in 1986, and certainly when I was a kid in the 60s and 70s, ice, ice, ice. But why? Effect of local cold pack application on systemic anabolic and inflammatory response to sprint interval training, a prospective comparative trial. The negative effect on hormones, which are part of the healing process. Local ice therapy immediately following sprint interval training was associated with a greater decrease in both pro- and anti-inflammatory cytokines, with a greater decrease in anabolic hormones. These results, along with the previously reported evidence for some negative effects of ice application on athletic performance, and no clear effect on muscle damage or delayed onset muscle soreness, may suggest that the use of cold packs should probably be reserved for traumatic injuries or used in combination with active recovery or massage, and not with complete rest. Boy, that acronym RICE is starting to be thrown out. Effect of ice on lower extremity functional performance and weight discrimination ability in collegiate football players. Potential negative effects of ice massage on proprioception are unknown. This study is interesting in that it questions why ice is effective for decreasing cutaneous sensations and its effect on the nerves in the skin that send signals back to the central nervous system, but it does not seem to affect proprioception. The study resulted in the following main finding: that both functional and performance tests, single hop tests and crossover hop tests, and the weight discrimination ability remain unaffected with ice application. Our study has shown that proprioceptive acuity in the hamstring muscle, as reflected in the ability to perceive differences in weight, is unchanged after 5 minutes of ice application. The final comment by the authors is that rapid return to play after icing may not be detrimental. May not be detrimental. But is it helpful? The effect of post-exercise cryotherapy on recovery characteristics, now we get to 2015. There was no evidence that cooling affects any objective recovery variable in a significant way during a 96-hour recovery period. Cold therapy significantly alleviated symptoms of delayed onset muscle soreness 24, 48, and 96 hours after the cooling application. So I think you can see, study after study after study, we do get some good pain relief. These findings can be useful for physical therapists, coaches, and physicians who work with athletes, especially athletes who perform exhaustive exercises or sports and possess only short recovery periods between training sessions or competitions could benefit from these findings. Cooling did not affect objective recovery variables such as lactate levels, CK levels, IL-6 levels, inflammatory markers. However, significant decreases could be observed favoring cooling at 48 hours. From the current results, one can conclude that cooling is superior compared to passive recovery strategies after various exhaustive or muscle-damaging exercise protocols. These results relate to the subjective efforts of different cooling applications. So here we're mostly talking about pain. Cooling showed significant effects in reducing the symptoms of DOMS compared to passive control. It achieved the best effect with respect to the other cooling applications. To sum up the individual results, the mean temperature of the studies showing a significant result favoring cooling compared to the passive intervention was 10 degrees centigrade. The reported and suggested cooling time for alleviating these symptoms was around 13 minutes, ranging from 10 to 24 minutes. Cooling did not significantly affect the objective recovery outcomes compared to the passive control interventions. Yet the authors concluded, despite the detailed analysis of the individual study results, it must be viewed with caution because the risk of bias was high according to the blinding procedures and remained unclear for the selection bias. What is the evidence for rest, ice, compression, and elevation therapy in the treatment of ankle sprains in adults? To analyze the effectiveness of applying rest, ice, compression, and elevation therapy begun within 72 hours after trauma for patients in the initial period after the ankle sprain. Rest. All included studies had a similar conclusion. Some type of immediate post-traumatic mobilization is beneficial in the treatment of acute ankle sprains. Ice. Based on our review, evidence from randomized controlled trials to support the use of ice in the treatment of acute ankle sprains is limited. C. Compression. Based on our review, evidence from randomized controlled trials to support the use of compression in the treatment of acute ankle sprains is limited. No information can be provided about the best way, amount, and duration of compression or the position in which the compression treatment is given, recumbent or elevated. And E. Elevation. No randomized trials were found and included in this review, so no evidence based on studies with high levels of evidence is available for the effectiveness of elevation. Should athletes return to sport after applying ice? A systematic review of the effect of local cooling on functional performance. Applying ice or other forms of topical cooling is a popular method of treating acute sports injuries. In competitive sport, this may occur during a game, pitchside, or at halftime. The premise is usually to provide cold-induced analgesia, and athletes will often return to competitive activity shortly or immediately after the application of a cold treatment. What did this paper find with their review? That muscle strength was decreased. That muscle endurance, well, there was conflicting evidence as to what effect ice had on it. Vertical jump, sprint, and agility ability, there was reduction of performance. Post-cooling return to play. Intramuscular temperatures have been shown to decline for up to 10 minutes after the removal of an ice pack. In this review, many studies have found that performance remained below baseline for at least 15 minutes following treatment. 2 studies indicated there were no performance detriments when participants undertook a 6.5 to 15-minute warm-up, dynamic joint movements and jogging, between the end of a cooling treatment and returning to activity. Cold versus heat after exercise. Is there a clear winner for muscle soreness? There is controversy as to the effectiveness of cold and heat after strenuous exercise. Some studies show that heat is better, whereas others favor cold, and others show little effect of either. The problem seems to be that when comparing heat to cold or examining either, there is no clear definition of what heat is or what cold temperature should be in the population being studied. Cold versus heat after exercise. Again, is there a clear winner for muscle soreness? Listen to this. Thus, the literature is in total confusion. Wow. Another complicating factor is the duration of cold and heat. The issue is one of physics and heat flow. Warming the muscles to core temperature is a slow process. First, subcutaneous fat buffers the gains in heat from the skin to the muscle. Second, basic heat flow equations show that the steeper the gradient, the greater the heat flow. But if heat is too elevated above the core, the skin can burn. This limits rapidly applied heat modalities such as hydrotherapy to 20 or 30-minute exposures. The same argument can be made for cold treatment, except that cold can be tens of degrees less than core temperature, so that heat flow from the muscle can be more rapid. But there's still a vast difference in the tissue penetration of hydrotherapy versus cold packs versus ice packs separated from the skin by 6 to 8 layers of towels. For some reason in athletics, it is believed that cold after exercise is the best modality to prevent swelling and damage to the muscle. At least for this age group, collegiate athletes, this is not true. There is a definite advantage of heat after exercise if applied or used immediately. Cold and heat both prevent muscle damage, but on balance, heat actually has small damages over cold in increasing healing after a heavy workout. You can see, boy, that the comment of the literature is in total confusion is very accurate. So, what did Gabe Mirkin have to say all those years later? Remember, his book was 1978. So let's continue with the quote that I read earlier. Gabe said, "When I wrote my best-selling sports medicine book in 1978, I coined the term RICE, rest, ice, compression, elevation, for the treatment of athletic injuries. Ice has been a standard treatment for injuries and sore muscles because it helps to relieve pain caused by injured tissue. Coaches have used my RICE guideline for decades, but it now appears that both ice and complete rest may delay healing instead of helping. Subsequent research shows that rest and ice can actually delay recovery. Mild movement helps tissue to heal faster, and the application of cold suppresses the immune responses that start and hasten recovery. Icing does help suppress pain, but athletes are usually far more interested in returning as quickly as possible to the playing field. So today, RICE is not the preferred treatment for an acute athletic injury." Wow, wow, wow. 1978 to 2015. And this paper is going to sum things up for us pretty nicely. The Cold Hard Facts of Cryotherapy in Orthopedics, 2018. 3 standard types of cryotherapy are prescribed as post-operative therapy in orthopedics: compressive cryotherapy, continuous flow cryotherapy, and the application of ice. All aim to decrease the amount of inflammation of the surgical site, reduce patient pain, and aid in the recovery process. The application of ice or other cooling pack devices without compression is the most commonly used method, likely because it is the most economical and user-friendly cryotherapy option. Compressive cryotherapy is the application of ice or an ice pack secured to the site with a bandage or other device in a manner that also applies pressure to the site of injury. Finally, continuous flow cryotherapy systems are typically connected to a refrigeration control unit and apply compressive cooling through the uninterrupted flow of cold water or gas through a wrap around the injured site. Current literature includes many studies monitoring post-operative outcomes in patients using cryotherapy as part of their treatment regimen, with the primary endpoints being visual analog scale scores, analgesic consumption, and range of motion. These studies do not provide conclusive evidence that cryotherapy significantly alters post-operative outcomes despite its ubiquitous use by the orthopedics community. The literature reflects a seeming lack of consensus regarding the effect of cryotherapy on analgesic requirements, pain, and mobility following these procedures. Though the makers of advanced cryotherapy systems market them as a vast improvement over traditional forms of cold therapy, there is insufficient evidence to support such claims. Even the most robust study that included 280 patients failed to show significant differences in the analgesic use and range of motion after surgery. A rigorous analysis of the benefits of cryotherapy ought to incorporate other factors in addition to improvements in analgesic consumption, VAS, and range of motion. These include the financial and time investment involved in the use of continuous flow cryotherapy, which the majority of studies do not consider. Though many authors acknowledge that continuous flow cryotherapy is expensive, to our knowledge, none have yet performed a formal economic analysis of the cost of advanced cryotherapy to the patient as well as to the healthcare system at large. Substantial savings may be on the table if future studies are able to prove post-operative cryotherapy shortens hospital stays, reduces medication costs, and results in fewer physical therapy sessions. Patient education required for optimal use of advanced cryotherapy is another aspect of cryotherapy that is poorly represented in the literature. Future studies should consider gathering data on patient and more holistic investigation of the role of postoperative cryotherapy in orthopedics. Now, there are adverse effects from cold therapy, like frostbite and compartment syndrome. As an example, a patient recovering from patellar tendon repair experienced bilateral frostbite and skin loss following 2 weeks of uninterrupted use of cryotherapy without any barrier between his skin and the system. A similar case study described 2 female patients, one recovering from total knee and the other tibial revision, who used cryotherapy systems without cessation and experienced frostbite and skin necrosis over the entirety of their knees. Third case, exploring 4 incidents of patellar frostbite and necrosis following knee arthroscopies, proposed that poor patient understanding of proper cryotherapy, as well as poor recognition of the signs of frostbite, contributed to these adverse outcomes. Personal story here, being a competitive power lifter since the days of chiropractic school, so that goes back to the early and mid-'80s. For me, when the ice packs came out, those chemical ice packs, put them in the freezer. Well, after a hard squat workout, I iced up my knee. This is in the mid-'80s. Fell asleep on the couch, and my knee was nice and white and crunchy afterwards. Not a good thing. So I definitely caused pretty significant frostbite to my knee. So you really do have to be careful. What are some visuals on this? Well, here you go. Photographs of preoperative knee with blistering from ice application. That is pretty ugly there. So let's get a good look at that so you remember what this looks like, and you can show this to patients. Don't make the mistake like I did of falling asleep. Definitely set an alarm on your phone to awaken you after about 10 minutes. Another issue with the cold packs in the freezer, some of them get really, really cold. It really does depend on the manufacturer. And even if you put a layer of something, whether it be a paper towel or a thin towel, between that and the skin, it can be quite problematic. So pay attention. Here's another photograph of a healthy 20-year-old man, post-operative knee with ice burns, secondary to the use of a continuous flow cryotherapy device. Those are typically better because that's water typically coming out of them, and the water's not going to get below 32 degrees. So that's kind of surprising, but you can see it's problematic. I have not had a personal problem with the use of those when I used to use them, and but this is a significant burn. Ouch, 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 ouch. So now, another acronym. In 2019, this was published in the British Journal of Sports Medicine, and they called it Peace and Love. So P, protection, avoiding activities and movements that increase the pain during the first few days after injury. E for elevation, elevate the injured limb higher than the heart as often as possible. A for avoid anti-inflammatories. It's a whole nother topic. Avoiding anti-inflammatory meds as they reduce tissue healing. C, compression, using an elastic bandage or taping to reduce the swelling. I don't know if any of you used kinesiotaping, but there's some pretty cool applications, excuse the pun, pretty cool applications of kinesiotaping to help the drainage, and they've certainly worked for me and the patients with whom I've used them. E for education. Your body knows best. Avoid unnecessary passive treatments and let nature play its role. We'll discuss that further with an interview that's going to be coming up. Love for load. Let the pain guide your gradual return to normal activities. Your body will tell you when it's safe to increase the load. Well, that does take some guidance and certainly understanding rehab. Most of my rehab comes from the strength and conditioning world. Again, as a competitor, I totally get load. So teaching patients how to load, when to load, really important skill set. Optimism, condition your brain for optimal recovery by being confident and positive. Well, a lot of people struggle after injury, so assuring them that they will recover and guiding them on that process will certainly lead to a more optimistic outcome. Vascularization, choose pain-free cardio activities to increase blood flow. There's a lot of cool things you can do there with movement. But any type of movement is going to, one, increase lymph activity, and number two, it's going to increase blood flow. And E for exercise, well, load and exercise, kind of the same thing. You're restoring mobility, strength, proprioception by devising the right exercise program. Really, really important. And here's a great paper, 2020. The year 2020, great journal. It's called thesportjournal.org. As with all these papers, the links are in the PDFs that are included. This is a great journal, and this is a really well done article, really, really nice review called The Rice Protocol is a Myth, a review and recommendations. And it goes over a little bit of the history. We've gone into it in a lot more detail. Couple of things that this article brings out with regard to periods of rest. So rest following an acute musculoskeletal injury does not enhance the recovery process. So when we're talking about rest, at least in my opinion, what we're talking about is, number one, we're going to stop the offending activity. It's kind of like getting in the ring with Mike Tyson. We don't want to get hit over and over and over again. So number one, we need to stop the activity that's causing the problem. Number two, how long do we actually rest, as in not move that body part? Well, that's going to be something that you as a clinician are going to have to decide. But again, 24 to 48 hours at most is the period of time where you're not going to move it. If it's incredibly painful, that's another issue. That's where some active and passive motion can be helpful, some isometric movements at different points in the range of motion. But that's for another course in terms of rehab. So just be careful when you use the term rest in defining what rest actually means. The lymph system. So the lymph system is responsible for draining the accumulation of waste products from the damaged site. In order to do so, this passive system relies on the voluntary contraction of the tissues surrounding the site of trauma in order to produce a propulsive force. So you're not going to get any lymph flow by laying there and not moving. Therefore, a period of stillness will not adequately evacuate the damaged site, and the area will remain congested with metabolic waste. This congestion can delay the completion of the inflammatory process, which will result in the inability to progress the processes of repair and remodeling. So we want to help the body get rid of the fluids that are building up in the area. Maintaining muscle fiber size and fiber composition requires contractile activity. Consequently, a period of inactivity will cause the muscles to undergo atrophy because the circulatory system cannot sufficiently provide nourishment or move waste from the affected area as a result of inactivity. The tissue will become weaker, less functional, and thus more susceptible to injury. That's why it's extremely important, especially if you've received patients from other providers who may have told the person to rest and the person has taken that at face value and has literally done nothing, and then they all of a sudden want to come back to their activity. Was that rest or inactivity an hour, a day, a week, a month? The assumption that they can just return to activity is a very, very foolish assumption. Therefore, continuing to activate the musculature surrounding the site of trauma is required in order to maintain muscle mass and avoid the possibility of re-injuring the tissue. Recovery from exercise-induced muscle damage, cold water immersion versus whole body cryotherapy. So these are two newer treatments. The principle of cold water immersion is to immerse part of the body, except the head, in a cold water bath in which the temperature is below 15 degrees centigrade for a duration of 10 to 12 minutes. In contrast, whole body cryotherapy consists of body exposure to very cold air, minus 110 to minus 195 Celsius, in a specifically designed room or device for a total of 3 to 4 minutes. They have a significant effect on reducing some biological markers of muscle damage and inflammation. Additionally, these recovery strategies have been shown to provide a beneficial effect on subjectively perceived soreness the day after exercise. This particular study showed that in a hamstring protocol, using cold water immersion was better than the whole body cryotherapy to improve muscle power, recovery 72 hours after the exercise. But what do athletes do? Well, here's some results from 2016 Olympic Summer Games. What did the athletes do? TIIB, the last acronym on the left side of Table 1, TIIB, Total Immersion Ice Bath. You can see that that was one of the most popular therapies that the athletes desired during the Summer Games. So they felt that total immersion ice baths were very helpful for recovery, and I want to make the distinction between they felt it was helpful for recovery, not injury care. We can even go into that a little bit more deeply with regard to what it's actually doing with regard to recovery. Certain studies say it can slow down muscle recovery, but it will enhance the parasympathetic effect. So it's very, very individualized, not saying not to do it, not saying to do it, but it's something that you need to know, either you yourself or the athlete. How do you feel afterwards, and how are you recovering, and can you really go after it? I wouldn't do activity immediately after either of those, the ice bath or the device, but it's really important to figure this out for yourself. I know for me personally, the ice is really a no-go. Local heat therapy to accelerate recovery after exercise-induced muscle damage. Well, this paper, Emerging Evidence, suggests that therapeutic effects of local heat may derive from reduced muscle soreness, increasing muscle refueling, stimulation of muscle protein synthesis, reversal of exercise-induced vascular and mitochondrial dysfunction. So now we're moving back to heat, which is a much more Eastern way of thinking. Talk to any Eastern medicine practitioner, and they'll give you 2 thumbs down to icing anything. So, is the Ice Age over? What are you really trying to do when you have an injury? Well, you're trying to prevent further loss, and you're trying to regenerate that which has been destroyed. And with that introduction, I am going to introduce the author of De-Riced, The Dark Side of Stillness, Gary Reinell. Do no harm, the unofficial battle cry of all things medical. Paradoxically, the most recognized, referenced, and recommended protocol in Western medicine, rest ice, compression elevation, or RICE, not only causes additional harm, it also inhibits the healing process. And now we are going to talk, and I have the distinct pleasure and privilege of talking with Gary Reinell.